Hello, everyone. Our topic today is Cachexia Anorexia syndrome. These are the objectives of the presentation. Definition. Cachexia is characterized by ongoing loss of skeletal muscle mass, with or without fat loss. Cannot be fully reversed by conventional nutritional support and leads to progressive functional impairment. Cachexia is distinguished from starvation by a number of features, including hormonal abnormalities, increased resting energy expenditure, continued weight loss despite caloric supplementation. Estimated prevalence of cachexia in Europe and United States is as high as 1%, with mortality rates ranging from 15 to 80%, depending on the type of chronic illness. Cachexia is a poor prognostic sign. It's totally different than starvation. It is an inflammatory process. From this table, you can find out that kidney failure is the commonest cause of cachexia, followed by AIDS, followed by cancer, followed by COPD and heart failure. Symptoms of cachexia, as simple as such: unintentional weight loss, skeletal muscle wasting, lowered quality of life, and anorexia or loss of appetite. There's been many descriptions to cachexia, and one of them is Evans, and another one is Fearon, and the last one is Screnio. Okay. With Evans, he said here weight loss of more than 5%, at least in 12 months or less, decreased muscle strength, fatigue, anorexia, low fat free mass index, and abnormal biochemistry by increased biomarkers, inflammatory biomarkers like CRP and interleukin-6 anemia, and low serum albumin. While Fearon classification, weight loss of more than 5% over 6 months, or body mass index of less 20 with any degree of weight loss more than 20, plus appendicular skeletal muscle index consistent with sarcopenia. Screening is weight loss more than 10% and presence of at least one symptom of anorexia, fatigue, or early satiety. Now, each of these have its own merits and it has its own problems. So as far as Evans, it is the best as far as predicting, as far as predicting the prognosis of cachexia. Use Evans because it has actually biomarkers, checked out, like CRP, interleukin-6, anemia, and the low albumin. But it's not pragmatic, to be used in daily life, okay, or in a clinical practice. So more reserved for research. Fearon is more pragmatic, but it doesn't have the abnormal biochemistry included, which is really an important thing to, in cachexia, to pick up the cachexia anorexia syndrome. Screenio is the simplest one to use, okay? However, it's really lacking a lot of other important, aspects like in Evans, the abnormal biochemistry, and for example, in Fearon, the appendicular skeletal muscle index that's consistent with sarcopenia. So you pick up and choose. I use the last one myself because it's very simple, and in a in a busy daily practice, um, this will be very helpful for me to pick up a cachexia anorexia syndrome. But it's not a perfect one. Okay, Fearon, again, definition as we mentioned here, and this is more a description of Fearon and the appendicular skeletal muscle consistent with sarcopenia and so forth. Um, Fearon has classified also patients into pre-cachexia, cachexia, and refractory cachexia. Evans, we mentioned Evans, and as I told you, this one is the most useful in research because it has most of the values needed, but it's not pragmatic in daily clinical practice. Again, this is Evans. And I want to mention something. I mean, you have to know the three classifications. I use the last one, the Screenio, however, in my daily practice, because I don't have time to, pull labs and do this, do that, to pick up cachexia. So I use something simple. However, you have to know the three classifications because in certain cases, you might need to pull up some labs, check the interleukin 6, the CRP, the this and that, okay, to verify that this is a cachexia anorexia syndrome and it's not something else. All right, I'm gonna talk about an important topic, and I think a lot of people really give a full explanation to these terminologies that really confuses every clinician here. Okay, so what is weight loss? Weight loss has been a valuable and core criterion in the formulating definitions for cachexia. And recent studies have refined the prognostic significance of weight loss by incorporating baseline energy reserves into the prognostic model. Malnutrition is often used as an overarching term that encompasses nutrition-related disorders such as starvation, cachexia, and sarcopenia. So malnutrition is the big umbrella, guys. Okay, underneath there is the cachexia, the sarcopenia, starvation. All right. Recently, a consensus-based set of criteria for malnutrition recommended the diagnosis of malnutrition to be based on either a low body mass index less 18.5 or on a combined finding of weight loss more than 10% indefinite time or 5% over 3 months, together with either reduced body mass index or low fat free mass index. I don't want to complicate it for you more than this. I mean, as far as you're concerned, just understand that malnutrition is the big umbrella that has the other three important terminologies underneath: starvation, cachexia, and sarcopenia. Okay, cachexia, we talked about it and we said cachexia is a metabolic and inflammatory process, okay, and cachexia carries a poor prognosis. It's characterized by hormonal abnormalities, such as elevated insulin and ghrelin levels, increased resting energy expenditure. We're going to talk about this later on in the presentation, in the pathophysiology, in full detail. Starvation is a severe deficiency in caloric energy intake associated with the loss of fat and little protein. Starvation can be reversed. You know, if you eat, you will reverse. Body composition. Um, I mean, this is basically a comparison between cachexia and starvation. As far as body composition, cachexia is loss of fat and skeletal muscle. Starvation is loss of fat, but small amount of muscle. Weight loss, cachexia, it's a complex metabolic and inflammatory process. Starvation is a simple nutritional deficiency. Treatment, cachexia, is multimodal, and starvation is protein calorie supplementation. Okay, I'm going to throw another definition here, make it a little bit more difficult. Sarcopenia is considered as muscle disease or muscle failure rather than purely low muscle mass arising from adverse muscle changes that accumulate across a lifetime, commonly in elderly folks. The European Working Group on Sarcopenia in Older People updated the consensus definition in 2018, focusing on low muscle strength as the key characteristic of sarcopenia, with low muscle quantity and quality confirming the diagnosis, and poor physical performance as indicative of severe sarcopenia. I think this makes it very clear that sarcopenia is not just about losing muscle mass. Okay, another definition is anorexia. What is anorexia? Primary anorexia is the loss of appetite for food. How about frailty? Frailty encompasses a lifetime decline of multiple physiological symptoms affecting physical, cognitive, and social dimensions. How about sarcopenic obesity? It's a combination of reduced low body mass and excess adiposity. The risk and prevalence of sarcopenic obesity increases with age and vary in definition and cutoffs. Sarcopenic obesity is independently associated with higher mortality and complications in the medical and surgical cancer treatment across multiple tumor types. Low muscle mass sarcopenia identified on imaging in non-obese patients is associated with decreased survival in both early and late stage cancer. Okay, and then so sarcopenic obesity, basically sarcopenia associated with increased body fat, and it carries a very poor prognosis. Okay, lastly here, osteosarcopenia occurs when the two diseases coexist, sarcopenia and osteoporosis. And they are linked in terms of common risk factors and biological pathways. Patients with osteosarcopenia may have a higher risk of falls, fractures, and frailty. So people that have osteosarcopenia, they will fall more frequent, they will have more fractures, and they will have frailty. Okay, number 10, nutritional impact system. These are the symptoms that can exacerbate the cachectic state by decreasing nutritional intake. Nutritional impact system include nausea, vomiting, constipation, diarrhea, early satiety, severe pain, dyspnea, anxiety or depression, stomatitis, dysgeusia, xerostomia, and dysphagia. So these are basically symptoms. Nutritional impact systems are basically, a cluster of symptoms that will exacerbate the cachectic state by reducing the nutritional intake. And I mean, if you look at it, all of these factors can reduce the nutritional intake. So this is something that you need to correct for cachectic patients. If you don't correct it, you will have poor prognosis. Okay, another definition is skeletal muscle infiltration, known as myosteatosis. It's an ectopic fat depot that increases with aging and is recognized to negatively correlate with muscle mass, strength, and morbidity, and disrupt the metabolism. Patients with myosteatosis might have, type 2 diabetes with insulin resistance. Prognostication. Several domains of cachexia are associated with poor prognosis, are shown to be associated with decreased survival in patients with cancer cachexia. Clinical signs: decreased appetite, nutritional impact system, changes in the body composition, such as sarcopenic obesity and sarcopenia, weight loss. All of these affect the cachexia anorexia syndrome, and thus they carry a poor prognostic features here. Other abnormal labs, such as low hemoglobin, less than 12, low testosterone, high C-reactive protein, which is an indication for inflammation, and low serum albumin. An association between low testosterone and decreased survival has been reported in male patients with cancer cachexia. Glasgow Prognostic Score is a simple systemic inflammation-based approach, basically using CRP and albumin levels with prognostic value independent of tumor stage, performance state, and treatment in variety of solid tumor. So GPS, okay, is a good screening scale for most tumors. Okay, Glasgow Prognostic Score based on CRP and albumin. Pathophysiology of CAS. So as I mentioned before, CAS is an inflammatory problem and it's a metabolic problem. All right, there are a number of factors that increases with CAS, such as interleukin 6, interleukin 1 beta, tumor necrosis factor, interferon gamma, and others. As you see from this nice picture here, with cachexia, there's increased inflammation and catecholamine. So it has two arms, inflammatory arm and metabolic arm. And this will eventually lead to, lipolysis, proteolysis, and excess energy expenditure. Guys with cachexia, they have, they lose a lot of energy. Okay, and next to it is the metabolic pathway that we mentioned. Okay, The most important ones is the leptin and the ghrelin. All right, the ghrelin, in fact, is the hormone that stimulates you eating. Leptin is the opposite. Okay, so a leptin that's produced from adipocyte is anorexogenic, while ghrelin, predominantly from the stomach, is orexogenic. Pathophysiology of cancer cachexia, proteolysis, white adipose tissue lipolysis, browning of white adipose tissue, increased resting energy expenditure, increased glycolysis, increased gluconeogenesis, lactate production, anorexia, reduced performance, reduced 6-minute walk, increased mortality. And then it has other effects on other hormones like parathyroid hormone and also on the expression of zinc alpha 2 glycoprotein. We call it ZAG. Again, pathophysiology of cachexia involves a number of hormones, and we mentioned two of them. Also, it involves insulin, adrenal hormones. I want to, make it simple for you, maybe, in simple terms, because the pathophysiology, as you see, is pretty complicated. Cachexia is metabolic and inflammatory condition affecting, I want to wrap it up in 2 words, affecting your metabolic and inflammatory condition, affecting your physical performance and carries a poor prognosis. This is, in a nutshell, the pathophysiology of Cachexia Anorexia syndrome. And it's a hypermetabolic state. It's not a hypometabolic state. So this is important because there is increased resting energy expenditure. There is more of the epinephrine, norepinephrine, and cortisol. So increased inflammation, hypermetabolic state, leading to poor physical performance and poor prognosis overall. I hope this kind of makes it simple. All these slides that I'm showing you are basically the same thing. Okay, just trying to explain the same thing. So I try to make it simpler, but I mean I find it's more difficult. But this is basically most of us like to watch soccer, and so I said, well, basically we have 11 cytokines produced in cachexia, and we have 11 metabolic pathways affected, such as the ghrelin, insulin, testosterone, epinephrine, and so forth. And basically, this is the end result of this match, basically between the cytokines and the metabolic. So to just make it as simple as I can, and this is basically the goals. Okay, this is the net result of this scary game here between the cytokines and the metabolic mediators here. Okay, I think we passed through the difficult part of the presentation here. Now we're going to talk about the tools. Okay, so one of the most important tools is what we call patient-generated subjective global assessment, short form. Again, these are for research, guys. We don't use them on daily practice. But if you're going to do research, you're going to need one of these. Okay, PG, SGA, and it's composed of, 4 items: weight, food intake, symptoms, and activities and function. As you can see, this is like something that you need to sit down with the patient and fill it up. Another tools for nutritional risk screening, malnutrition screening tool is called MUST. Another tool, nutritional risk index. Another tool is malnutrition screening tool, or MST. Another tool, simplified nutritional assessment questionnaire, or SNAC. And basically, they found that the MST had the greatest ability to detect cancer cachexia. Again, all of these, are research tools. MST. Just remember the names. That's all you need to know. I mean, I'm not gonna ask you to, but if you're gonna do a research on cachexia, you're gonna need to use one of these tools. Okay, MST, then MUST tool, and then you have the SNAC tool, or short nutritional assessment question. All right, and then we have another tool, function assessment anorexia cachexia therapy, or FAC. We have another one called the European Cancer Cachexia Questionnaire. This is number 7. So we have 7 tools up to now. So this is basically the FAC questionnaire. Number 8 is simple. It's body mass index. Number 9, anthropometrics. Okay. And here, mid upper arm circumference. The anthropometrics depends on the mid arm circumference. Here. Anthropometrics are basically measurements in the human race, in a simple term. Triceps fold thickness. Also, this is anthropometrics. Okay, another tool for assessment is bioelectrical impedance analysis. And this is a non-invasive, probably inexpensive, and uses a constant low-level alternating current to measure impedance. Guys, this is one that you will see in the malls when you go into a mall and they ask you to weigh yourself and all that. You can get the bioelectrical impedance analysis here over there. And then we have the phase angle, a direct derivative of reactance and resistance measurement correlated with outcome. Bioelectrical impedance analysis. I'm sure you've seen this kind of machine in the, And then we have the DEXA scan. All of you guys know the DEXA scan used for picking up osteoporosis. This is important in cases of osteosarcopenia in particular. DEXA scan. CT scan, okay, allows us to see, body composition analysis, and it's done actually at the level of third lumbar vertebra. In addition, we have the MRI, and this is useful in picking up something like myosteatosis, which is basically fat in the muscles. It can show muscle attenuation. And then ultrasound is also a very useful machine, and it analyzes the muscle rectus femoris. Okay, and this is a good reliable index of the total quadriceps volume and change in response to an exercise intervention, for example. Okay, CT scan at level of L3. Okay, this is sarcopenic patient, and this is not sarcopenic patient. Look at the muscle is more developed here, all over than over here. The upper one, the red coloration is the muscle. As you can see with sarcopenia, it's affected and less so with non-sarcopenia. Ultrasound for rectus femoris muscle. Another tool is the short physical performance battery. Number 17 is the hand grip strength. Number 18 is the 6-minute walk test. And I'm sure all of you guys, know about the 6-minute walk test that we use for dyspnea, and we use it, in cardiac patients and COPD patients. Short physical performance battery, balance, gait speed test, and 5-chair stand test. Hand grip, dynamometry, 6-minute walk test. And then we're going to talk about therapies now. I think we had like 18 tools that are used in Cachexia Anorexia syndrome. Okay, what does this tell you? It tells you one thing, that Cachexia Anorexia syndrome is a very complex disease. As I said, I'm just simplifying things, but it's way, way complicated. I said it's metabolic, it's inflammatory, it affects your basically body weight, affects your physical performance, affects your prognosis, and of course affects your quality of life. Okay, so how are we going to deal with it? So this is not just reversing the nutrition only. There's so many factors playing together, and that's why our approach is called combination therapy, all right, or multimodal therapy. For some reason, they like combination therapy here. For some reason, I don't know why, but this is, when you look at the literature, they talk about combination therapy, but basically it denotes multimodal therapy. Like in pain management, multimodal therapy for pain. This is multimodal therapy for CAS. Okay. Targets for therapy: anorexia and metabolic disturbances, nutritional support, nutraceuticals, drugs. Objectives being, kind of balance the anabolic catabolic, pathway here. Try to be more anabolic, less catabolic. That's the bottom line. Combinations therapy is most likely to be the most effective management strategy. Exactly, guys, like you're doing multimodal therapy for pain management. If you just use one medication or one technique, it will not do the job. You have to use multiple techniques and medications to achieve your goals. As simple as such. Again, they call it combination therapy in CAS for some reason. Okay, nutritional supplementation. So to begin with, the most important thing here is the nutritional supplementation, and especially proteins. All right. Emphasis should be placed on maintaining a daily goal of 1 to 1.5 gram per kilo per day of protein. And based on the guideline recommendation, the caloric intake should range between 25 to 30 kilocalories per kilogram per day. We love to use these food supplements, such as Ensure or others that has high protein and so forth. Also, we love using a lot of omega-3 polyunsaturated fatty acids. Vitamin D is extremely important. Omega-3 essential fatty acids can be found in different types of food, such as flax seeds, walnuts, pecans, salmon, and olive oil. Psychological intervention is also extremely useful in Cachexia Anorexia syndrome. And basically, we're trying to teach cognitive reframing strategies. Remember this terminology here, cognitive reframing. Cognitive reframing, okay? Basically, cognitive reframing helps with the Cachexia Anorexia syndrome. Aerobic and resistance exercises. So we have, both of these can help out with the Cachexia Anorexia syndrome. That's why we focus on rehab after the patient develops cancer, and because this can really keep him up in shape. Okay, we're gonna jump into some of the medications used in Cachexia Anorexia syndrome. We'll start with metoclopramide. Metoclopramide is a dopamine 2 antagonist, and it's a prokinetic. It helps with, gastroparesis. It helps with, constipation, increased motility. So it does help, quite a bit in these folks. However, the main drawback is extrapyramidal side effects. Primpran or metoclopramide. It should be used before meals. Olanzapine. There's a lot of interest on olanzapine. Olanzapine is an atypical antipsychotic, and it increases appetite. And it's really very useful in nausea and vomiting, and helps with agitation. Olanzapine is right now an important drug in Cachexia Anorexia syndrome. Unfortunately, it can cause hyperglycemia. It can cause metabolic complications like hyperlipidemia and so forth. But for these folks, it shouldn't be that of a lot of concern. These issues. It could be of concern to somebody that's healthy and doesn't have a cachexia anorexia syndrome kind of thing. Start with 5 milligram at bedtime. Mirtazapine. Mirtazapine is a drug that helps with depression, helps with sleep, helps with It helps with increasing. It helps increasing the appetite. It's not a very strong medication as far as this concerned, but you can try it. As well. It's not going to hurt to give it a shot, especially if the patient is depressed. Um, Unfortunately, I want to say that uh, mirtazapine 15 milligram once nightly was no better than placebo in CAS, which aligns with the 2020 guideline recommendations. So, as I said, this is just a personal experience. Give it a shot. It helps with so many domains in cancer patients, and it might help with appetite. So, but it's not a recommended drug for CAS. Corticosteroids still a very important, drug in CAS uh, because uh, because of its effect on different cytokines like interleukin 1 and 6 and tumor necrosis alpha. It also reduces fatigue. Unfortunately, giving steroids for long term has a lot of complications. So for short term, definitely it could be effective. It helps also with the nausea, uh, you know, um, and also the sense of well-being. So I usually give it only for 2 weeks. I don't exceed 2 weeks, and I use dexamethasone, very abundant drug all over. You can use IV or injection. Progestational steroids, and the most important one is the megasterol acetate. Unfortunately, it's very good drug as far as increasing body weight. However, there is a higher risk of thromboembolic complications with the megasterol acetate. Now, I want to mention that there's megasterol 40 milligram per ml here. This is not for cachexia. I just put it here to confuse you a little bit. This one, we use it for hot flashes, the small, tiny dose, 40 milligram. But if you're going to do for cachexia anorexia, you should start with 160 and go your way up to 400 milligram to 800 megasterol daily. Cannabinoids, all right, they have a role in AIDS patients, okay, and also in patients that has chemotherapy related nausea, but not necessary in cachexia anorexia syndrome. One of the famous drugs is dronabinol. By the way, I use this a lot. It doesn't really make you high as people think it is. It's not. But it does help with the appetite, especially, as I said, related to chemotherapy or AIDS. And these folks, usually they have anorexia and have nausea. Beta blockers have been shown to be useful in cardiac cachexia. Okay, and cardiac cachexia is involuntary weight loss of more than 6% of non-edematous body weight over the last 6 months. I want to say that this definition is specific for cardiac cachexia. The rest of cachexias is basically defined like we talked about at the beginning of the presentation, using the Evans or Fearon or screen your criteria. Beta blockers helps in these situations. One of these drugs is carvedilol. Testosterone, all right? I every once in a while I do really check testosterone in my patients, palliative patients, and I always ask the oncologist before I start the testosterone if they have low testosterone levels, because low testosterone can cause fatigue as well. All right. Uh, I've seen it in patients that are taking high dose opioids. Okay, 100 milligram morphine or its equivalent, for long term. They get also low testosterone, and they get fatigued, and they lose appetite, and they lose their performance. And I use this simple testosterone injection, 200 milligram per ml. When you check testosterone, check both total and free testosterone. And this one, you give it on a monthly basis, IM injection. Testosterone cypionate. Ghrelin. This one is the hormone that we talked about, useful for, especially in COPD patients, and it's been shown to increase, the mean body weight and also the performance status and the 6-minute walk test, and reduces the exaggerated sympathetic drive that we see in cachexia. Remember, I told you cachexia is a hypermetabolic state. Okay? Ghrelin is an appetite stimulator. Leptin is appetite suppressor. Ghrelin, this is still, as far as I'm understand, in research mode up to now. This is basically a wrap for different types of medications used for cachexia anorexia syndrome. All right. I would say that the most important one here in all of these at this point is dexamethasone. Maybe things will change in the future. Okay. For short term, dexamethasone for short term would be my most important medication. This one, the megasterol, is not a very good idea in patients that have a higher thromboembolic, tendency here. And in fact, actually, if you think about it, most of cancers, they have higher, incidence of thromboembolic complications. Metoclopramide is important for patients with gastroparesis and impaired motility, but they have a higher incidence of extrapyramidal symptoms. Dronabinol has been approved for AIDS and chemotherapy-induced nausea and vomiting. Ghrelin is a hormone useful mainly in COPD patients, and it has a lot of advantages over other medications, but I think it's up to now under investigation. Key learning points. Malnutrition, sarcopenia, and CAS are complex challenges for researchers and clinicians in daily practice. Improved understanding of CAS and its mechanisms allows for the development of new targeted agents and better insights into how these therapies could be incorporated into effective multimodal management. CAS is also an opportunity for collaboration between palliative care teams and oncology colleagues to improve patients' quality of life, decrease treatment toxicity, and improve performance status. Importantly, palliative care teams have the skill set to implement the necessary basic assessments for CAS, a comfort with a model of interdisciplinary care that integrates with other health professions, and the expertise for optimal management of nutritional impacts symptoms. Thank you.